program of the Medical School Center for Biomedical Ethics and Humanities. I'm Marcia Day Childress from the center, and I'm happy to welcome you to this program this afternoon. A program called Caregiving, Revitalizing its Place in Medicine. This Medical Center hour today is quite a special event, the School of Medicine's Kopacka v. Rao Lecture in the Medical Humanities. For many years now, the Kopacka Family Foundation has funded this annual lecture, established with an eye toward improving the care of dying persons and improving, too, health professionals' communication with ill and dying patients and their families. UVA is one of many medical schools to receive Kopacka Family Foundation funds. Mrs. Sita K. Rao established the Kopacka Family Foundation in loving memory of her husband, Dr. Kopacka v. Rao, a medicinal chemist who rose from impoverished beginnings in a small village in India to earn advanced degrees in science. Dr. Rao emigrated to the U.S. to pursue further studies. Once he was established here, he had a rich and productive career, both in pharmaceutical research with Pfizer and in teaching pharmacy at the University of Florida. He loved his work and believed passionately in scientific discovery and in teaching, in service and education, and in being a good human being. This gentle and accomplished man and his wife raised 3 children, 2 of whom, Jaya Rao and Ram Kopacka, became physicians. Dr. Jaya Rao did her internal medicine residency here at UVA. She's now on the faculty in the School of Pharmacy at UNC Chapel Hill. She joins us here today, welcome Jaya, as we remember and celebrate her father with this lecture, which occurs just 9 days after the anniversary of his death many years ago. Dr. Kopacka Rao's last illness at age 72 proved tragically troubling for his family. His 2 physician children wrote an impassioned piece for the Annals of Internal Medicine in 2002 about how their father's doctor's communication with the family could have been better. Well, basically, there was no good communication. And how perhaps those same doctors could have cared better for Dr. Kopacka Rao and his family had they known more about their patient as a person. Luckily, one physician who knew the family provided compassionate advocacy that made all the difference. But except for him, as Dr. Rao's son and daughter wrote, quote, "We longed for a physician who knew our father as more than just another case." Our Kopacka lecture today addresses caregiving, the hands-on work of caregiving for our fellow human beings who are ill or dying. Our speaker, the very distinguished medical anthropologist and psychiatrist Arthur Kleinman, comes to us from Harvard University, where he has been a longtime member of both the medical faculty and the Faculty of Arts and Sciences, and where he also now heads the university's Asia Center. You'll find his biographical sketch unbelievably abbreviated in your handout. Best known perhaps for his 1988 book, The Illness Narratives, Arthur Kleinman was doing medical humanities before we called it medical humanities, and he has shown many of us the way. In recent years, several of his former students, distinguished now in their own right, physician activist Paul Farmer, physician writer Pauline Chen, medical sociologist Nick Christakis, among them, have all spoken at Medical Center Hour. Why not their mentor? What an oversight that was. So forgive us. But we invited Arthur Kleinman this year, and we're so grateful that you accepted. He comes to us with knowledge of his subject, caregiving, deep and rich, drawn from clinical and intellectual and global cultural traditions, but also, importantly, now from the heart, from home, as he'll share with us. Welcome, Arthur Kleinman.
Thank you. Thanks for the kind introduction. Good to be here with you. The topic of caregiving is kind of a difficult topic, and we're going to spend some time on it, so I thought I would start with to lighten the atmosphere for us with a story, because I've been giving this talk at medical schools across the United States, and so I was trying to figure out myself why I'm doing this. And it reminds me of a story of the story of a soloist who was an expert on the glass harmonica. And he was asked to play at the New York Philharmonic, the first soloist on the glass harmonica ever asked to do this. And he practiced, and he went and played the Bach preludes. He launched into the preludes, played them all, and then at the end there was a standing ovation. In the back of the room, a small voice cried out, "Play it again." to which he responded, "I'm so delighted with the response, I will play it again." And he played one of the last preludes again. Again, a standing ovation, and the small voice again, "Play it again." To which he responded, "I'm exhausted, I can't play anymore." And the small voice responded, "You play it again until you get it right." So that's what I'm trying to do. I'm trying to get it right. And as was just alluded to, besides being a physician and researcher who spent much of his career looking at caregiving and doing caregiving professionally, for the last 10 years until she died a year ago, I took care of my wife who had early onset Alzheimer's disease, which eventually killed her. So I want to begin with a set of paradoxes, 3 paradoxes. The first one is, where is caregiving in medicine today? And the overall topic is, where is caregiving in medicine today? And the 3 paradoxes are: the paradoxical place of caregiving in today's medicine, which I'll explain, the paradox of caregiving in medical education, and then the question of, does caregiving paradoxically suffer from scientific and technological development in medicine? Now, paradox 1. So medicine clearly, traditionally, has defined caregiving as central to the practice of the doctor. Over time, however, by any set of measures that we would use of the content of what physicians do, caregiving has become less central to medical practice. Paradoxically, we don't spend sufficient time or money on caregiving, yet we still consider it central to what medicine does. Paradox 2, medical education. Evidence suggests, and there's a lot of evidence here, that medical students are both more interested in and better at the practical, emotional, and moral aspects of caregiving when they enter medical school than when they graduate. This must be upsetting to any medical educator. The paradox is that this suggests there's something about medical education that actually disinterests and disables students from caregiving. This will be a strong part of my argument, that medical education, at the same time that it enables doctors to be very effective as in a technical realm and using technology and in professional practices of other sorts, disables them in caregiving. So we could put forth a Swiftian proposal. Remember that Jonathan Swift was a writer who, during the Great Irish Famine in the 19th century, suggested as a paradigm, as a proposal meant to shock people, that what should be done was that the children should be eaten, because that meant that he said that you could take away people's hunger by eating the children, and secondly, we would save the children from suffering, from starving to death. And what he meant to do was to provoke outrage, which he did do. And so I want to put forth a Swiftian proposal that medical schools could consider dropping caregiving from the curriculum and handing it over to nurses, home health aides, social workers, and families, who in fact are the people who do most of it. But when posed this way, and I can tell you this from, I've had plenty of experience on this, no medical educator or head of a clinical department, and I've spoken to hundreds, is willing to consider removing caregiving from its iconic place in medicine. And in fact, the usual response is, what, are you crazy? And when you say this, so there is this gap, this enormous gap between what we profess to think medicine is about and what the actual practice of medicine is about. Health reform and technology. Now, in my view, health reform has worsened, not improved, the human condition of caregiving in medicine. Technology has come to dominate our understanding of healthcare, replacing or diminishing in significance the human acts of caregiving. I witnessed the electronic medical record, which I spent some time working on. I believe it's incredibly important, and there's a lot of evidence that increases efficiency, evaluation reliability, and protects patients and leads to a lot of gains. But often, if you think of it from a caregiving perspective, there's no place in the electronic record to include information about the illness narrative, the experience of healthcare, or from the clinician's standpoint, the very tasks of caregiving. It doesn't have to be that way, but that's the way the medical record has in fact developed. Witness also the fragmentation and time compression of care in institutional settings, where big structural factors from time through the organization of the routine of care, of practicing itself, reduce the amount of time that is spent with patients on what I'm going to define as the central acts of caregiving. Also, hype about advances in the pharmaceutical science has led to a tendency for doctors to depend on miracle drugs rather than a nuanced understanding of the individual and their experience, or search for such interventions. So that brings us to what is caregiving. If we look at caregiving in the Oxford English Dictionary, we see that it's characterized by the needs of others and our attention to those needs, whether they're professional or social. And it's attention to people who require assistance, such as children, the elderly, invalids, people who are end of life, etc. Now, we can define the core tasks for family, close friends, the sufferers themselves, and professionals. And by the way, this is not me. I mean, I'm just simply summing here what has been written by many, many people about caregiving. You can go back, as I mentioned earlier today, to the wonderful notes to nurses that Florence Nightingale wrote in the 19th century, in the late 1860s, to see some of these, many of them, defined even as early as that. So we can think of a whole bunch of the tasks being practical assistance, with activities of daily living, with amelioration of pain and suffering, with protecting people who are vulnerable to an injury. But there's also another set of tasks, which are acknowledgement and affirmation of the personhood of the care receiver, and the opportunity to express, and giving them an opportunity to express their illness experience and what's most at stake for them and for intimate others. Caregiving is also about, as anyone who's been involved in it knows, with emotional support and counseling. And it's about moral solidarity, what could be said is responsibility and engagement of the caregiver when little can be done, except being there for someone. For the professional, and here I'm thinking of particularly of physicians, could be nurses, could be others, diagnosis, prognosis, and treatment can also be performed in ways that emphasize their deeply human consequences, as well as their technical expertise. Regrettably, usually they're not, but they can be. This includes being aware of the fact that we are trained to pathologize things, and that pathologizing things isn't always the way to proceed, the best way to proceed. As you see right now in the big controversy about the American Psychiatric Association's decision to turn grief into a disease. Consultation and coordination with financial, legal, religious, medical, and psychological advisors makes us aware of the fact that caregiving goes beyond medicine. It's fundamental to what families are about. It is an important part of the social world. It also involves sustained engagement with people over the course of chronicity and in the terminal period. And yet the models we often have for caregiving tend to forget the importance of the long term and the sustainability, the need to sustain caregiving.
Turn on your.
I did turn on.
Okay, move it down a little bit. It's not.
Can you hear me better? Okay. Caregiving is also about, I can speak very loud, so if you just I was born in Brooklyn. So. Now, caregiving is also about something that I call presence, which is being there existentially for people, just being there in our humanness, in the fullness of who we are, as opposed to sort of being there professionally in a mechanical way that's bureaucratic and mechanical and indifferent. One of my colleagues, Michael Hertzfeld, has written about what he calls bureaucratic indifference. Well, presence is the opposite of bureaucratic indifference. So caregiving has an important relationship to the moral, at least as I see it. It's an existential act that in some ways defines our humanity and our relationship with others. It's one of the things that really does matter in life. It's a basic response to the context of danger and uncertainty that defines most of the human condition everywhere. Certainly in poor societies, but even in a wealthy society like ours. In practice, caregiving is not just simply a burden. Of course, there's a burden to caregiving. There's a financial burden to caregiving. There's a time burden to caregiving. There's a psychological burden to caregiving. But caregiving is also the ontology, the way of being, the way we animate and live our lives. And as I'm going to get to, it's not only about everyday moral experience, but it also can be about our ethical aspirations, what we feel is right, what we want to really emphasize. In a global culture of cynicism, where there's such a strong sense of misplaced loyalty, caregiving is frequently perceived, and this point is constantly made in the literature, as one of the truly worthy objects of ethical commitment. Now, on a practical level, if you simply sum up where caregiving is done, you look for all caregiving acts and see which part of them fall into different domains, then you find that caregiving has relatively little to do with medicine and even with the other helping professions. Most of caregiving actually occurs with partners, in families, and in wider social networks who are responsible for the everyday realities of living in illness, suffering from its consequences, and undergoing treatment and living, in the art of living in response to those things. Now I want to point out that technologies don't necessarily have to run counter to caregiving, as I mentioned with the electronic medical record. The robo-nurse, I don't know, nurses will let nurses talk about the robo-nurse and the robo-bear, but I can tell you that that when my wife was not only blind and demented from her Alzheimer's, but became paralyzed, if someone had invented, as they're doing now, an exoskeleton that I could move into and use to lift, it would have been a great invention, been very, very helpful to me. And there's an example of where technology in the future may actually, if we think about it carefully enough, could actually help with caregiving. Now, caregiving has a funny relationship with social status. It has not been associated with the highest social status. Let's say in the health professions, if you look at social status running with economic reimbursement, then we see that the surgical subspecialties provide some of the highest social status. We don't think of the surgical subspecialties as a place where most of the caregiving is being done, in fact. And families who are, in a sense, when it comes to the medical system, on the lowest of the social statuses, as I mentioned earlier, give most of the care. Much of care is provided by women, and it's strongly associated with immigrant groups in our society, with ethnic minorities and immigrant groups. In Boston, if you look at, again, at the content of caregiving, much of it is given by home health aides, by nurses, assistants, and many of them come from the immigrant communities in my town, from Haitians, from Irish immigrants, from a variety of the immigrants, Central Americans, etc. Now, if we actually look at the experience of caregiving and try to define it ethnographically, that's in terms of a description of that lived experience, we can see that caregiving is both the individual and collective human practice of giving care, because it's not just occurring at the level of an individual, but it's interpersonal and can involve an entire community. It involves the things that I mentioned earlier: protection, practical support, solidarity, and we can break it down into the different domains that I put here. It's necessarily reciprocally linked to the process of care receiving. Care receiving doesn't get enough attention in the literature. It's a critical dimension of this, and I'll try to emphasize this. The quality of the relationship, the nature of what's done, what's occurring, shows that it's thoroughly interpersonal, the caregiving and the care receiving. It's trans-subjective, as it were. Now, I've written a number of books in which I thought I really understood caregiving, both in the illness narratives and what really matters. And even when I gave the Tanner lectures at Stanford some years ago on experience centers, moral modes, I thought I really had a handle on it, but I didn't until I actually was a primary caregiver myself for my wife. But I want to use some of the ideas I developed there to try to get at what caregiving is about in its most basic way. So at the experiential level, we just think about any kind of experience, what we do in life, how we live our lives, the art of living, what we do every day. An experience is characterized everywhere, this is an anthropological truism, by an orientation of overwhelming practicality. That we have dangers and uncertainties in life, we have things that have to be done, and the telling aspect of human life is we get them done. We're extraordinarily practical. It is moral, in my sense of the word moral, experience, because there are certain things at stake, most at stake, for us as individuals and as part of collectives, as small groups. And experience is realized in local worlds, in our families, in our networks, in our laboratories, in our wards, in whatever our local world is, so that it's social as well as individual. You can identify. You go up on a ward, if you're in a laboratory, if you're in a classroom. There are certain things that are at stake for the group, and also for the individual. They don't have to be the same. There can be a conflict between collective and individual aspects of caregiving. Now, to understand the moral aspects of caregiving, which is really what I want to do now, in the limited time I have, I want to emphasize a way of looking at the moral that comes from my book, What Really Matters, and that I've been, in a sense, projecting in a series of articles I've done for The Lancet. But moral experience, which I've just talked to you about, is that life is about values, and just being alive, negotiating important relations with others, doing work that means something to us, living in some particular place, indicates that moral experience is inescapable. This means that caregiving always occurs in a local moral setting in which not just caregiving, but other things are at stake for families or institutions, which may constrain caregiving, and frequently do. Moreover, the life of the individual, of each of us, is moral, because most of us, I'm not saying all, but most of us want to live a moral life. There are people who are tone deaf to this, no doubt, and the like, but by and large, I think, when we look across worlds, we see an awful lot of evidence that people want to do the right thing. This means that when we give and receive care, it's part of what is at stake for us as individuals. Now, caregiving is embedded in both things, both moral experience, that is the life of a small group or part of a family, a network, a community, and also our own subjectivity. Now, I want to distinguish this from ethics and say that they're both important. Ethics we can think of in two ways. I'm sure there are other ways as well, but these are the two ways that are important to me. Ethics, first of all, is a professional discourse, a normative language of elites, ethicists, about the good and the just. And that's been incredibly important because we've learned an enormous amount about virtue and about principles of social justice that have come out of that incredibly important ethical discourse. But ethics is also part of our moral life in the sense that, if you think of it the way I just put it, in the local worlds that we're in, we often aspire to be critical of what we think is happening in the local world that we don't think is so good. And we want to go beyond it. And to go beyond that local world to put those aspirations that we have forward. We have aspirations for the ethical, aspirations for values that go beyond the local. And this is also critical for caregiving. I'm going to rush ahead a little bit because I think I'm behind on where I want to be. Now let me just illustrate some of this and give you some pleasure, I hope, by looking at artistic and photographic representations that get at this connection, the connection between suffering and caregiving, and get at some of the points I've made about caregiving and place them into different historical and cultural traditions. So a great dimension of why do we have caregiving is in Kathy Kolwitz's marvelous piece, Lamentation, which gives a sense of suffering, that human suffering is a part of all of our experiences, and that caregiving is a response to that human suffering. And that caregiving takes place in spaces between people is illustrated in the following settings that vary by, obviously, our economic status, what kind of hospital we're in. But that caregiving is an interpersonal experience between us, is constantly revivified for us just simply by looking at people. Now, I want to emphasize this care-receiving point and point out to you that even in the most cognitively devastating disorders, the care receiver is a person. And their personhood doesn't just disappear because of cognitive decline. So this is a small sample of the self-portraits, there were many of them, by William Untermining, an artist who chronicled his own experience of the progression of Alzheimer's disease through his paintings. You can see here, as Untermining struggled to present it, he had a sense of self and a sense of presentation of self, even as he entered severe cognitive decline. And then to show the history of caregiving, I mean, just briefly, this is actually something you're all aware of, but to just do it quickly for us. This is a Flemish portrait of the rule of the Hospital of Notre Dame in Tournai. And here you have sisters, nursing sisters, providing care. Rembrandt, in many of his paintings, emphasized the domesticity of caregiving. This is his wife Saskia in bed with an attendant or a family member with them, and the idea of the domestic space of caring for someone else. This, I think, is one of the most profoundly interesting paintings from relates to medicine's changing role with caregiving. This was a great painting from 1894 by Sir Luke Fildes called The Doctor. It doesn't illustrate fully here, but in order to see it fully, in the background, if you look hard enough, on the other side of the room from the doctor, is the mother of the dying girl who is bent over in sadness and with her head on the table, and her husband with his hand touching her on the shoulder. You see the deep emotional and moral dimensions here. But look at the doctor himself. The doctor now unable to do anything technically, simply watching the death occurring and thinking not just about the disease processes, but about the human experience and reflecting his own humanity in that portrait. I like this painting very much because I think it suggests that caregiving is not just about sickness, but caregiving is part of the relationships that we have. And this portrait of that Rembrandt painted, he meant to convey, as art historians tell us, the caring dimension of marriage. And here's Picasso at the bedside in a painting very similar to, but of course in a different genre, to the one we just saw, also giving a sense of a kind of embeddedness between the caregiver and the care receiver at the bedside. Of course, the classical depiction of this in the Western tradition is the Pietà. This is Michelangelo's example of it. And in the space between the dying or dead Christ and the Virgin, that space is the space of caring. Rembrandt, again, painting a Portuguese Jewish doctor, a famous one of his era, capturing in the face the compassion, the acknowledgement of the caregiver. One of the great moral portraits. But it's not just the Western tradition that has emphasized this, and since I'm a China scholar, I'm going to spend a little time on Chinese images. This is from the Yangon caves. Again, scenes of the Buddha experiencing the importance of caring. This from the Dongwang caves, from Western China, from Afghanistan, from Japan, from Nigeria. What is most impressive in all the images is the interpersonal space. It's just not just the action of the caregiver, nor is it just the suffering of the care receiver. It's the embeddedness of the two together. This is from Partners in Health, an NGO at Harvard that my former students, Paul Farmer, Jim Kim, and Ophelia Dahl, set up. And again, the quality of the family-centeredness, the interpersonality of caregiving. Now, this is the only time we know that Picasso drew the head of a medical student. And what art historians tell us is important here, and I believe it, is one eye open and the one eye closed. And if we think of medical school, maybe, if you bear with me for a second, maybe students come in with both eyes open. You think of all the tremendous interest that students acknowledge in their medical school applications, or that they project as themselves in terms of what they want to do through medicine. And both eyes are open. And if you think of your first encounter with patients, the awe-inspiring sense that you're entering someone's life, that you're able to do something maybe useful, that you're just listening, auditing that experience of pain and hurt and injury, gives you an empowering feeling. But over time in medical school, one eye closes. And it closes, obviously in part to protect the self. So if both eyes are open, you might be less than able to carry out some of the difficult professional tasks of caregiving, which are technical and very specific. But on the other hand, as one eye closes, maybe it really shuts and becomes so self-interested that you're in danger of having both eyes closed. Of course, the doctor with both eyes closed would be a dangerous doctor. So Picasso was trying to tell us a truth, another truth that I think is just captured, and I'll give you another way before I get to the revitalization of caregiving in medicine, just as a sort of final statement on the moral aspect of caregiving. Henry James, in a wonderful short story of his called The Middle Years in the Aspirin Papers, you know, at Harvard, the Jameses were from Harvard, and we say of the Jameses that William, the psychologist, was actually the great writer, and Henry, the novelist, was the great psychologist. and Henry had this to say. He said he has in the Aspirin Papers an elderly writer dying of heart disease being taken care of by a young doc. And the young doc harbors a secret, which is that he also wants to be a great writer. And the elderly dying, his elderly dying patient intuits this and means to convey some wisdom to the young doctor, both about writing and about caregiving. And he says, we work in the dark, we do what we can, we give what we have. Our doubt is our passion, and passion is our task. And I think anyone who's done caregiving recognizes that central to the moral or emotional experience of caregiving is that doubt. Is that doubt as to whether we can be effective or not, whether we're up to the challenge, whether we can maintain our lives in the middle of caregiving. And I think this is not just what family members feel, but this is also part of what the threat of caregiving is to professional caregivers. That maybe there's not enough time, maybe there's not enough energy, maybe there's not enough presence to be able to actually do this in a routine way, in a regular way, I should say. Now, with that as sort of background, I want to jump right ahead so that we can have some discussion to a proposal to revitalize caregiving in medicine. And I'm saying that caregiving is in desperate straits in medicine today. And that if we don't revitalize it, we're on the point of really such a fundamental break from it, it may be irretrievable in the future. So here's some ideas that I have. I'm sure you guys have as many, if not more. The first year of students, experience of students should include time in the homes of seriously disabled or terminal patients, practicing primary caregiving, not doing anything that's medical. Simply assisting with feeding, bathing, dressing, toileting, ambulating. That's what made me a caregiver. That's what makes those of you who've been caregivers in the family a caregiver. This is something that Leiden Medical School routinely does in Holland. And when you debrief their students and speak to their graduates, you see it has a profound effect on them. That this is something they keep with them for a long period of time. They don't forget. They don't lose a sense of what living a serious illness, a debilitating illness, a terminal illness, a health catastrophe, what living it is about. In the preclinical years of medical school, writing a mini ethnography of a patient and their family and network. A lot of schools do this, but we should systematize it. And we should actually evaluate it in the same way that we evaluate any skill of the student. In subsequent years, more collaborative activities with nurses, physical therapists, home health aides, to encourage, on the one hand, respect and collegiality, and to learn from people who actually do much of the professional caregiving. Longitudinal clinical experiences in home health care are also important. And then systematic evaluation to show that this is important and to actually use this in the admissions process. So some years ago, I was taking a group of Harvard medical students around the Brigham and Women's, one of our hospitals, and interviewing patients together with them. And afterward, one of the students said to me, "You know, Dr. Kleinman, we're the wrong students for you." He said, and he said, he meant to be helpful. And he said, "We're simply the wrong students. You know, we were selected entirely on cognitive grounds. Okay? You want students who have some other skills." And so, and I said, "Yeah, yes, you know, there's something to that." And the fact of the matter is that our admissions office, probably like yours, has changed substantially over the last 20 years as to in admissions. So that, you know, now, for example, in our first 2-year classes, the last 2 years, about 20% of each class has been students who have been majors in the humanities or the social sciences, maybe 25% in some instances. So an increasing number of students who already come in with an academic background relevant to the materials that I'm presenting. We also need affirmation of the importance. What do I mean by that? I mean very simply, you know, I'm giving you this lecture. You know, I'm an academic, but I also was a clinical. I was in charge of a clinical service for part of my time. The service chief sets the agenda. You turn to your attendees and you say, "This is the kind of behavior I want to see emphasized. I don't want to see that behavior emphasized." That has a big effect. And you show it in what you do. You show it in what you do and what you value. And I think that affirmation has to start right at the top. It starts with deans, it starts with department heads, and it goes right down to the service chiefs. And we expect the attendees and the residents to follow suit. And then more time in curriculum and training, much more time, has to be devoted to this. Now, to revitalize caregiving in medicine, in medical institutions, we've got to give much greater resources to this. So it's astonishing if you actually plot out the amount of resource given to the teaching of caregiving in a medical institution. It's very, very minimal. That's why I said there was an enormous gap between medical educators saying, "Well, we'd never give this up. This is part of our identity," to what is, well, okay, that's great to hear. Then how much resources put in relatively little has to be increased. Building caregiving process measures into the electronic medical record, and not just the medical record, but into evaluation, as I suggested, is very, very important. And therefore, we have to have those process measures. Evaluating caregiving skills is central to the competence of the clinician. You're not good at caregiving, you flunk as a clinician. Innovate research on the process and outcomes of caregiving. We need much more in this area. And then there's a policy implication, which is to develop, well, this is one of them, there are many policy implications. One of them is to develop an equivalent to the environmental impact statement, which would be a caregiving impact statement. So whenever we assess an intervention, we ask, what's its intended and unintended potentially unintended consequences for caregiving. Now, to revitalize caregiving in medicine, let's strengthen also the doctor as a caregiver, and some of the things I just mentioned loom large now. So we incentivize caregiving. Now this means, if you think about it, this means very substantial changes in the way we do things. So that, you know, the hidden teachers in medical training are the residents. Residents are survivors. I was a resident, and I value residents greatly, but we were all survivors. We do, you know, we try to do things in a shortcut in a short period of time because the pressure is so great to do so many different things. All those conflicting values of good things that we want to accomplish. Well, if we incentivize caregiving, then we have to incentivize caregiving for residents so that they're able to model caregiving and also do it, practice it. I think this is very, very critical. If you just look at the amount of time that residents spend in the rooms of patients in training facilities and academic units, you find that it's minimal time, and that much of the time that residents are sitting before screens, computer screens, they could be with patients. There have been multiple studies of this, but they're not. Education and the core skills. So I laid out before the core skills, but systematically going through and saying, we're going to educate each of these core skills. We're going to train people. Going beyond bureaucratic protocols to emphasize the humanness of any of the interventions we do. Recognizing that the training of the physician is a moral training. The best study of this that I know of is a classic book by Charles Bosk, Forgive and Remember, about the moral training of surgeons. That we are training people and inculcating values. But what are those values that we're inculcating? Are they the right values? And complementing an economic language with a clinical caregiving language for policy and programs. A very important thing to do. That is that, I may be a little harsh in what I'm going to say now, but if you look at the healthcare debate which we've had in the United States, we've had several years of a healthcare debate, and that debate is almost entirely about cost. Now, there's nothing wrong with focusing on cost. It's very important. The economics of healthcare are crucial. But there's another side to healthcare, which is caregiving. How often has that been projected into the national debate? Hardly at all, I would say. And I think this is a failure amongst all professional caregivers, that we have failed to project the issues that I'm talking about into a policy debate. And until we do that, the structures won't change in such a way as to support the kind of skill development and practice that we want to see in these domains. Now, some years ago, Dwight MacDonald, who was a major American cultural critic, had the following to say. I think each man's values come from institutions which are peculiar to himself. I'm sorry, it shouldn't be institutions, it should be intuitions. Intuitions which are peculiar to himself, and yet, if he is tolerated as a moralist, also strike common chords that vibrate respondingly in other people's consciences. This is what ethical teachers have always done. It is the only way we have learned anything essential about ethics or communicated our discoveries to others. And I truly believe that this is the case, and this is why in the medical setting, I believe it is the clinicians who have a special responsibility to carry the issue of caregiving into and to enact it, to animate it for students, so that students routinely see it modeled, recognize the expectation that they're going to be assessed on this, recognize the need to learn these skills and put them into practice. And so it's this intuition that I want to encourage, that I can just tell you, I more or less do what I'm doing now with you for a living, and I've been in so many places, hospitals and medical schools, where you can see the clinicians with this intuition, and yet the intuition is not effectively conveyed, and that's what I want to argue for. So my sense is that this is a talk about, in a setting, emphasizing communication in the practice of medicine. I want to say that communication is based on something. It's not just a series of technical skills, though it does have some technical skills. It's based in relationships. It's based in relationships that turn on how we affirm and acknowledge another person, how we listen to them, how we respond, the way we explain. I'm sure all of you know the studies that compare orthopedic surgeons with chiropractors, which show again and again that orthopedic surgeons and chiropractors are perceived radically differently by patients with back pain. The patients with back pain perceive the orthopedic surgeons as inexplicable. They can't explain things, whereas the chiropractors can explain things. Well, there's no reason why an orthopedic surgeon shouldn't be good at explaining, or any doctor. Just think of the difficulties in this regard. Were any of us trained in thinking about the metaphors we use to talk to a patient about their leukemia, or their heart disease, or their depression? Has there been any systematic thought to the way we work through in our mind the metaphors we quickly grab onto and use when we speak to patients? No. None of us have been trained adequately, I think, in this regard. There's a lot to be done. But I'm saying at the base of it is a moral reality, and that's what I want to leave you with. I want to suggest to you, at the very core of what this presentation has been about, the recognition that comes out of my own experience as a primary caregiver, that medicine is losing a vital dimension, its connection, its moral connection to patients. That should we lose this, we will transform a profession into a technical practice. And that when we do that, something important that we all recognize is important may be lost for a long period of time. And that loss will be reflected not just in our own impoverishment, but in the impoverishment of the experiences of patients. Thank you very much.
We have some time for questions and comments from the audience, and I will bring a microphone to you so you can identify yourself and ask your question.
One person there.
Okay.
I'm Fern Hauk in the Department of Family Medicine here. I'm sorry I had to step out for a second, so I might have missed this, but I was really interested in hearing more about your experience with your wife, if you're willing to share that, and how that caregiving experience as a family member as opposed to a physician affected you and your feelings about the kinds of things you're presenting and how that...
Yeah. Sure. I mean, I can say a few things. See, I've written this up in a bunch of articles that are available. But there's no question about the fact that one of the articles that I wrote talked about how it humanized me, how it made me more sensitive, more responsive kind of a person. Part of my experience was that there was a quality to caregiving which wasn't just burden, as I said. That part of it is learning how to be present to others and to do acts. And that the very phenomenon of caregiving was not talking about it, not thinking about it, but I became a caregiver from doing it. So what I'm saying is, this is sort of William James's radical criticism, that a caregiver is someone who practices caregiving. It's in the practices that you become a caregiver. It's the physician putting his arm on someone in the practice of speaking to them. in taking a pulse, not just taking the pulse, but giving a sense of a human connection. It's the way we talk to someone. It's how we assist them in ways, how we protect them in an interview, how we respond to their vulnerability. It's in that ability to practice that, to bring it forward in our lives. That's what I learned in my, and I learned that there are a lot of obstacles to this. So I was mentioning earlier today that some of my friends are some of the great neurologists at Harvard, were friends of mine. They meant to help me in every way possible. They were great at diagnosis, and they used what limited treatment there is available for Alzheimer's disease. They knew very, very little, almost nothing, I'd say, about the long-term caregiving needs of family members, which was astonishing to me because much of what they do is dealing with neurodegenerative disease and with stroke, et cetera, where this is routine. So there must be something disabling in their own experience, as there is, I believe, in medical school, that literally disables them from attending to what they would normally attend to. And I think that that's one of the things I'm trying to emphasize here, the kind of culture of neurology, or the culture of medicine, and how that works against what we want to see happen. I think a lot of people could say that to you who are primary caregivers for family members.
Yes, I'm George Mentor. I'm actually in the Anthropology department right here. I'm also actually the current editor of the journal Anthropology and Humanism. I'm not trying to boast about my status, I just want to let you know that I'm a big fan of yours. So could you do it one more time?
I got it wrong. I know I got it wrong, but I can't remember where exactly.
I had my question set up. I've been a fan of yours for a long time, and my question was actually a pedagogical one, because we've got a lot of students here. I was going to ask you what you thought the anthropology was. Where was the anthropology? Where is the anthropology and everything we do? But listening to what you just presented, and I think it was not worth repeating, because it was so well done. I'm going to be a little selfish today and ask you a question that has to do with my own research, and that is, everything that you said so far sounds a lot like, but you didn't mention this term, empathy. And I wonder whether you thought all the scholarship that's been on empathy at the moment would fit into what you're saying.
Yeah, I think that's a great question. I mean, I'd have to just start the lecture all over again to address it. I think empathy is a lot of what I'm saying. And it's interesting to see the response of many medical educators to empathy. So you'll find a substantial number of medical educators who believe that we should train physicians in sympathy, but not necessarily empathy, with the feeling that empathy may lead to a degree of identification and blurring of the lines of across the professional patient boundary that is in some way injurious or will lead to negative outcomes. I totally disagree with that, as I'm sure you do, and I think that emphasizing empathy is critical. The reason that I didn't spend much time on empathy is that the psychologists have grabbed hold of empathy. Okay, and with good effects and with not so good effects. And my own effort in this is to bring, well, the kind of things that your journal is interested in. Anthropology. The anthropology I'm interested in is the phenomenology of lived experience. And there's so many aspects that lead to a wisdom about the art of living that come out of that are buried in wonderful ethnographies, monographs, and articles, but never get projected. Even in my subfield of anthropology, medical anthropology, by and large, medical anthropology have not felt the need to project that in such a way as to have a practical effect on others. And I don't think the discipline is necessarily rewarded that. It's rewarded more the kind of academic work we've all done with. But if you think of almost everything I've said here, I think a key contribution comes from anthropology. Identifying the structural barriers, looking at the local moral worlds, understanding how you would shift crucial things culturally so they weren't such an obstacle or a disabling phenomenon. Attending to the very the deepest quality of lived experience. I think that is what anthropology does. And insisting that simultaneously with the subjective, there is an interpersonal world. And it's that interaction between the two that's so critical. It's that moral experience in the local world and that moral dimension of subjectivity coming together that makes this so complicated and so difficult. I think those are all the, the contributions that anthropology makes. And so I have no question about the fact that anthropology had a lot to contribute here. I kind of like today, to be honest, I like the term medical humanities because we have so many sub-disciplines in the social sciences: medical anthropology, medical sociology, medical history, the medical aspects of political science, medical economics, that we need some sort of a broader-based terminology that brings us all together on this and emphasizes that existential dimension of things. And I think that right now a good term is medical humanities. I had mentioned earlier that I didn't realize I did the medical humanities until I was awarded the Doubleday Medal of the University of Manchester Medical School for the medical humanities, and I told them I'd never heard the term before. This was about the late 90s. And then the next year, Imperial College London gave me another medal for the medical humanities. And I thought, I should take this term seriously. And I think there's something to it. And we just hired a wonderful historian psychiatrist, David Jones, to run our medical humanities program at Harvard and to try to bring the academic side of it in the Faculty of Arts and Sciences of historians and literary people and anthropologists together with the practicing physicians who have much more practical interest in the arts and humanities, from music through poetry to painting, etc. How you bring that together, I don't know. I have no idea. But I know that if we do bring it together, something remarkable is going to happen in medical education.
I'm Melvin Jansen, one of the staff chaplains here at the hospital, and your pictures helped me remember a learning exercise I had when I was in seminary, which is with pastoral care professor had us sculpt the family system. And so there'd be just a chair set up, and we were to take the person who had the power in the family seat on the chair, and then everybody else was arranged around that chair in relationship to the dynamics of that family. I remember how powerful that was for me as a person, but I'm wondering how, if we could use that kind of exercise in the training of doctors to understand the context of the patient within a family system, and that might be a learning tool to do family sculpting.
Yeah, I think it's a great question. I have taught twice a course on religion and medicine, and I think medical students, the Harvard medical students who we put into CPE training, into clinical pastoral education, had a terrific experience. On the other hand, I think religionists can fall into the same problem that physicians fall into. And so, for example, I remember a medical student who was at the bedside of a Episcopalian patient who asked the medical student, where does the soul go at death? This patient was dying. And the medical school student responded in a way that I thought was terrific, which was saying, well, why are you asking that question? And got into the feelings about dying that this patient had. But the person I was teaching the course with was an Anglican priest who said, you made a mistake there. That's a technical question, she says, where the soul is for Anglicans and Episcopalians. And my own feeling was, at that point, religionists were just like surgeons or internists. They weren't moving the ball forward.
I'm afraid we've come to the end of our hour. Those of you who have questions, technical or otherwise, are welcome to come down and take just a few minutes to talk to Dr. Kleinman. He's going to have to be leaving to catch a plane. But thank you all for being here today. Thank you to Arthur Kleinman. Please join us next week.